A very good evening to all the esteemed doctors who are present here today. My name is Vivek Pandey. I'm the lead marketing for sleep and multiple sclerosis business for EISAI India in the region. First of all, on behalf of EISAI India, a very warm welcome to all of you on this Sunday evening because it's a leisure day after a hard work of practice for entire week, and you all have gathered here. So truly a true appreciation from our side in this. But what in next 1.5 year we're going to witness is a true scientific carnival, a feast in the management of insomnia from none other than Dr. Felizi, who has traveled all the way from US, and she has been traveling from last 3 days across fourth city, and this is the fifth city that ma'am is coming live. Uh, and there is no other thought leader in entire world who has this knowledge of sleep medicine and how she has shaped how sleep is managed across the globe in over last 1 decade. So ma'am, thank you once again, and hope the last one has to be as good as the first four. So with this, I'll just take another 2-3 minutes of you to explain that what EISAI is all about, and what why this evening matters to us. So with this, EISAI is a heritage company with close to 84 years of legacy now. And we proudly call ourselves a human healthcare company because whatever we do, the patient remains at the center of what in managing the disease. And with this, we have a very strong presence of research and development in the area of neuropsychiatry and oncology across the globe. And we have close to 40 subsidiary across, and close to 11,000 employees are working to make sure the innovative research oriented product reaches where there is a need. And as I said, it being a Japanese company, we're not just based out of Japan in Asia, but we have true presence across Europe, North American, South American market, and an Indian market across all the Asia Pacific countries. And what distinguishes ourselves is the knowledge center. We have close to 14 drug discovery centers across the globe, research and development center, clinical research sites, and 9 production sites. And it's an honor to tell you that India at Vishakhapatnam, we have one of the important knowledge center where we house close to 450 research scientists. We have a drug development research committee there. We have an API production. We have formulation and packaging. And from there, we innovate and keep that access to entire globe. And this comes from one single philosophy that EISAI works with is human healthcare. At every point of time, we try to spend our 1% of time with the patient need wherever there is a challenge. And with this entire manufacturing, the R&D, and our philosophy, this is how we try to reach out to patient and make a difference in their life. And that all started with Aricept. As you know, the original research donepezil that is sold in India. We have changed the paradigm in 1996 in the management of Alzheimer when there was no hope. Immediately soon, we came into epilepsy with Zonegran, which is zonisamide, which remained in India as a research brand and globally. And some year back, we came with one more research innovation that is first of its kind in Ficompa, that is perimpanel, that has its own space now within a very short period of time. And why we have gathered is not just epilepsy, we have also moved into insomnia and launched India's first DORA. And India is the third country where this DORA is available. And this is where the topic of discussion lies today. And I'm very proudly to tell you that just a week back, we have got now an SEC approval in India to launch Leqembi. Again, entire paradigm shift in management of Alzheimer. That is going to be the first map in India in management of Alzheimer. And soon, Indian patient, where there are millions of it, will be able to access it. And not only that, we have another research. We have a very strong presence along oncology with Heleven and Lenvima. And and not only that, we continue to work in the area where we don't have our therapies also, like working with children with special needs, like cerebral palsy, autism, through an NGO and through our support to them. And at the same time, women with mental health in areas where there is no access to medicine and therapies. We try to reach out through NGOs and continue year on year supporting in this field. At the same time, we know we are innovators, and sometimes it is very difficult to have an access. And that's why we have framed a very strong patient support program across all our therapy, be it memory clinic, that is for Alzheimer, and that has set the benchmark not only in India, but across the globe. We have for epilepsy, we have leave free, where hundreds of patients every month get that access of medicine of innovation at their doorstep at a very affordable price with a lot of support in managing the condition which are chronic in nature. And why we have gathered today? Because in India, sleep remains one of the important challenge. And Tevigo in 3 years has become the second largest hypnotic brand in India. And we are committed to ensure that millions of Indians who suffer from insomnia get this benefit because this remains one of the first of its kind drug in India. And still, a lot of scope is there. Apart from insomnia, how do we manage a neuropsychiatric condition? And this is where we have Dr. Filizi today to take us through that. But before that, I'll like to call my counterpart, the lead medical affairs for neurology and psychiatry business and multiple sclerosis business in India, Dr. Darshana Digi. I'll do this.
Good evening, everyone. Thank you, first of all, for joining us on a Sunday evening. We are happy to have you all to hear the keynote speaker for today's event, Dr. Filizi. Ma'am has traveled all the way from US to help us understand the critical role of orexin in sleep medicine, to give us the newer perspective of orexin regulation in overall human body. She's been traveling with me for past 4 5 days. We have traveled across the entire country. She has delivered some awesome lectures where we have received wonderful feedbacks, and today being the last day, this is the last event that we ma'am would be delivering her lecture, none other than Bangalore city. And we are very grateful for you, ma'am. Despite the situation in India, you traveled with me, and a warm welcome from all of us today for this event. Along with her, she comes with a rich experience from the in sleep medicine and of course from the global end. But along with her, we have a esteemed panel who would help us understand the real world challenges in India. And that's where we have a mixed panel of neurologists and psychiatrists who would be joining us today for the panel discussion. I would like to introduce a quick introduction, not much. The chairperson for today's event, Dr. Andrade, sir. We all know him. Sir has been the adjunct professor, Department of Psychiatry in Kasturba Medical Hospital, Manipal Academy of Higher Education. He's been delivering lectures. He is the globally recognized expert in psychopharmacology, in ECT, the ketamine therapy, and research methodology. Sir, I welcome you for today's event. The moderator for today's session is Dr. Jagdish sir. Sir is a consultant psychiatrist and director at Abhaya Hospital. Sir doesn't require much of introduction. He is been very well recognized all over India. So, sir, I welcome you for today's event. The panelists for today's event who would be joining us for the discussions are Dr. P.T. Shivakumar. He is the professor of psychiatry and head of geriatric psychiatry, Department of Psychiatry, NIMHANS. Of course, his areas of interest remains Alzheimer's disease, geriatric depression, healthy aging. And sir, I welcome you for today's event. Then we have with him Dr. Vinod Kumar, the head of the SYNC Positive Psychiatry Foundation, Bangalore. I have interacted with him a couple of times, and the kind of rich experience and the thought process he has, it's amazing to hear him. And today I look forward for your panel discussion. So I welcome you for today's event. We have the neurologist who would be joining us for today's panel discussion, Dr. Shivakumar, Director Pune Neurospeciality Clinics, Bangalore. He also heads the Department of Neurology, Epilepsy and Sleep Medicine, Manipal Hospital here in Bangalore. Sir, I welcome you for today's event. We have one of our favorite doctor who has come all the way from Trivandrum, Dr. Divya. She is the additional professor in neurology from Sri Chitra. She has been the most, her areas of interest apart from neurology is sleep medicine. She's been doing a lot of research in sleep medicine. So ma'am, I welcome you for today's event. Today's session is being webcasted to 4 locations in India. And I would like to welcome the chairperson and the moderators of different locations. From Jaipur, we have Dr. Sharma, Dr. Khandelwal, and Dr. Mittal, who would be chairing and moderating the sessions. At Dehradun, we have Dr. Garg and Dr. P.R. Ravinash, who would be chairing and moderating the sessions. At Chennai, we have Dr. Rangarajan, Dr. Satyanathan, and Dr. Ramachandran, who would be chairing and moderating the session. And at Erode, we have Dr. Kanchana, who would be moderating the session. So I welcome the chairpersons and moderators of the hybrid location also for today's event. Now, I would like to introduce our keynote speaker for today's event, Dr. Felizi. Ma'am doesn't require much of introduction. We all know her. She's globally recognized for her extensive work in sleep medicine. She is the Benjamin and Virginia T. Bosch's Professor in Neurology, Professor of Neurobiology at Northwestern University. She is the ex-president of the World Sleep Society in 2022-23. There is a lot to read about her, but trust me, I have interacted with her last year. Past few days, I've been interacting with her, and the kind of research she's been doing in different, the kind of research she's been discussing with melatonin, with orexin, it is fantastic. And today, trust me, the next 40 minutes, what the lecture that ma'am would be delivering would be outstanding. So ma'am, welcome to you, and over to you for your session, please. Ma'am, be careful here. It's very narrow. Just be careful.
Okay, great. Sure. I don't, I think this is, okay. Excellent. This is forward. You have the best AV from all the cities. You can do it in one thing. The other ones I have to switch back and forth. So congratulations, this is great. So thank you so much for attending on a Sunday evening. I know that this is taken away from your family, and it's really a great pleasure to be here. It is an honor to be part of this really great panelists. This is very distinguished colleagues here in India, and especially in Bangalore. I've actually never been here, so this is a wonderful city. It's beautiful, even coming from the airport, a bit tropical. And I said, this is really, I will have to come back here. So I'm going to today talk a little bit about the importance of sleep and also the neurobiology of sleep very quickly, and then dive more into the insomnia disorder and also the treatment of insomnia, which will be mainly focused on the orexin system. Of course, there are many other systems, so I just want to say that in the spirit of balance, that there will be a stronger focus on the orexin system. So I want to start by saying why sleep is so important, because it's been there from the very beginning to some extent. Maybe not the EEG sleep, but the rest activity cycles. So really from the very beginning, the rotation of the Earth on its axis, you have this extremely prominent light and dark cycles. Light is extremely powerful as a time giver or zeitgeber for the circadian system, but also for sleep. So circadian rhythms evolutionary were earlier, they evolved in many ways to be able to be the internal environment to be synchronized with that of the rotation of the Earth on its axis. Then later comes sleep and wake, and reptiles, little higher animals, where you then clearly have this rest activity state. And in mammals, you have that EEG, whereas in the fish, you don't have an EEG or that you can record. So sleep is not defined by electrophysiology only. It's defined by metabolic activity. It's defined by perhaps even bioenergetics, both at the cellular level, at the mitochondrial level. It's affecting all this metabolism at different levels of organization. And also, there's a lot of data now on inflammation or immune disorders. For us, we focus on sleep and wake because it's the most obvious of all of these circadian rhythms is sleep and wake. And you can see that we need to be aligned. When you're active, there is light. When there's darkness, there should be a rest period. And this is true whether you are a single cell organism to very complex humans. But of course, in our modern society, and certainly for probably for ever since the beginning, there are some people who suffer from insomnia or difficulty sleeping, especially as one gets older, because there is an alteration in the sleep and wake system. More recently, I'm sure many of you have been very excited, especially the neurologists are very excited by the idea that during sleep, there's memory consolidation, but also during sleep, you're flushing out these large toxic molecules like A beta amyloid and tau, and perhaps others. Sleep is also affecting the blood-brain barrier. Sleep is affecting the oligodendrocytes, the astrocytes. So it's really a very important area that can affect brain health overall. So if you don't sleep or you have very disrupted sleep, there could be the accumulation then of these large molecules, toxic molecules like A beta, which is one of the causes perhaps of Alzheimer's disease. Not a cause of Alzheimer's disease, but certainly a part of the pathobiology that we see in Alzheimer's disease. So very conceptually, this is very simplified, but I want you to see how these systems interact and what can go wrong in people who have sleep disturbances. So conceptually, there is the sleep homeostatic process. We call that the S process for sleep. That's when you record your REM, non-REM, all of that. That is your sleep process. What happens when you woke up this morning? Your homeostatic need or drive for sleep is the S process is increasing in a linear way, up, 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 so that you get sleepier and sleepier and sleepier, supposedly. But you don't, right? You don't get sleepier and sleepier except in the afternoon. So, but then that could be there's several molecules or substances. One that's most common is adenosine. That could be the S process. So as adenosine increases, you get sleepier. And I'm sure you are drinking coffee, caffeine, or masala tea, right? They all contain some caffeine. And so caffeine is an adenosine receptor antagonist. So what it's doing is antagonizing this buildup of the sleep homeostatic process. And that process is dissipated during sleep. The adenosine levels go down when you actually sleep. It's just one of the homeostatic mechanisms. Now, in relation to this, interacting with the system is a circadian clock system. The central clock is located in the suprachiasmatic nucleus in the anterior hypothalamus. However, the genetic machinery of the circadian system exists in nearly every cell of your body: skin, muscle, liver, every cell of your body. And that genetic mechanism is ticking in every cell of your body. So when you change the timing of sleep, when you change sleep, you change rhythms, you're going to affect the whole body. I would say sleep is of the brain before the body. So it's really, so this is what I think has been quite exciting in my 30 years or so in the field, is to go from this EEG-based, the sleep in performance and mood disorders, all the way really to the application in many other conditions. The other thing that this clock does in the SCN, it also produces an alerting signal that counteracts, as you can see, the buildup of the S process. So the reason why it's so late now at 9 or 8 p.m. you're awake is not because of this S process, it's because of the circadian process. It's keeping you awake, counteracting this. And then something beautiful happens. The SCN sends a signal through the spinal cord to the pineal gland, and it secretes melatonin. Melatonin decreases the firing rate of these neurons in the suprachiasmatic nucleus. So now you have strong sleep drive, and you have now low circadian alerting drive, perfect time for 7 to 8 hours of sleep to occur. So your ability to consolidate sleep during the night is the interaction of these two systems. And then we have the orexin system that really in some opposite way to melatonin is high during the day. It's high during the day and it decreases during the night. And there's still a little bit of orexin tone during the evening, but it is much, much lower. So what can go moderate problems? There's sex differences between sleep regulation. Women tend to have more deep sleep, more slow wave sleep, even as they get older. So from a sleep standpoint, they do age a little bit better. Lifestyle changes can certainly affect this synchronization, this beautiful harmony and dance between these two systems, and of course, disease. All of these can either decrease the need for sleep or the drive for sleep because you can't build it up, or there's less wake propensity. People with sleepiness, they sleep during the day and they cannot build the homeostatic sleep during the night, and so they keep waking up during the night because it's not strong enough. Or as we get older, there's a decrease in melatonin in most older individuals, not always, but in most individuals. And that can then promote more wakefulness as well. Or you have a high orexin tone, hyperactivity of the orexin system during the evening and perhaps into the night. And all of these, any one of these mismatch can produce insomnia or can at least increase the vulnerability for developing the disorder of insomnia. So we're going to focus a bit on the orexin system. But before I do that, I also wanted to show you about the sleep and wake regulation. It is crucial, this small number of neurons, 50,000 to 80,000 neurons in the lateral hypothalamus in the perifornical gray area, send huge projections all to all the monoaminergic nuclei, dopaminergic, serotonergic, and even, and noradrenergic, but to the locus coeruleus, but also to the areas of cholinergic regulation. So you can see these are all neurotransmitters that are activating, right? They're active, these pathways are active during wakefulness. Now, sleep then, on the other hand, is started by activity of the neurons in the ventrolateral preoptic nucleus. We call it VLPO. It is GABAergic and it's galaninergic. So there's two, GABA and galaninergic. So when that gets activated, when the ventrolateral preoptic nucleus gets activated, it also sends inhibitory signals to the same regions that the orexin system during the day is sending excitatory signals. So you can very simply conceptualize sleep as perhaps active inhibition of wake rather than something that just tones everything down. It's really inhibiting wakefulness. And this is why I think the orexin mechanism is quite interesting. If you think about the neurobiology, if it's really decreasing inappropriate wakefulness, it makes a lot of sense. So I'm going to talk about the orexins. There are two orexins, peptides. The protein is A1 or B, and we call it 2 as well. And they sit on these receptors or G protein receptors. The orexins have slightly, the different orexin receptors and have slightly different effects on sleep and wake regulation, but they're both involved in sleep and wake regulation. So when you activate both the orexin-1, orexin-2 receptors, they're responsible for transition of the REM sleep into non-REM sleep, and also non-REM sleep into wakefulness. So what this is telling me is that the orexin system is a stabilizer of sleep and a stabilizer of wakefulness. So because you can stabilize wake. So it's not itself, in my opinion, a stimulant. It's not norepinephrine. It's not dopamine, okay? Rather, it requires, your orexin requires this pathway of the brain to be able to actually stimulate and activate the cortex. So when you then think about insomnia disorder, is this then a disorder of arousal, excessive arousal? Well, most of us think that way, that we've been taught that that is a hyperarousal, or perhaps merely an imbalance between the sleep and wake regulatory systems, like I mentioned, that it could be any of these systems. It could be also, of course, your orexin system. This is a cartoon that I drew just to make it very simple. So when you're awake, your neurotransmitters, your norepinephrine, histamine, dopamine, serotonin, and acetylcholine are up, are activated. These nuclei are firing, and they're secreting these neurotransmitters. The sleep favors GABA. When there's a lot of high GABA tone, you go into sleep. But GABA receptors are very broadly in many parts of the brain. But in the VLPO, it is fairly specific. So when you have GABA, it will then shut down. It will promote sleep. The role of the orexin system, on the other hand, is to stabilize these two systems. So when you're awake, you're stably awake. You don't keep going like narcoleptic patients every few minutes, every few hours, and fall asleep, right? And by virtue of allowing you to stay awake throughout the entire day, it also promotes your sleep homeostasis and promotes and allows for stability of sleep as well during the night. So think of it as a regulator or a little orchestra conductor there that is going back and forth, regulating sleep and wake in a bit of a seesaw pattern. All right, so in addition to receptors and pathways in the areas that regulate sleep and wake, there are orexin receptors, for example, in the prefrontal cortex, mainly the different receptors, receptor number 2 in the prefrontal cortex, also in the anterior cingulate cortex. And you can see areas, nucleus accumbens, lateral hypothalamus, amygdala, hippocampus, and thalamus. So all of these bring now to mind that if there are receptors there, the orexins must be doing something there as well. And so I think that brings us the idea that the effect either of an agonist or of an antagonist, such as a DORA, has potential implications beyond sleep and wake. So for example, the stress response, pain modulation, where there's high activation of the sympathetic system, reward addiction, we'll talk a little bit about that. I won't talk about feeding and weight, but it's clearly involved in metabolism. In fact, the word orexin comes from appetite, orexigenic. And before they knew it had anything to do with sleep and wakefulness, it was discovered, I think it was by Merck, I believe, and for something that would regulate obesity. At the time, but it did not work out for that. Cognition, delirium, mood disorders, and also neurodegeneration. So I'll give you a few examples, not exhaustive, that there may be you can at least generate a hypothesis that there may be a role in these conditions where insomnia is very common in depression and bipolar disorder. So hypothetically, based on some of the animal studies, these are not the strongest studies in the literature, that there appears to be a relationship between levels of orexin in the plasma and that of serotonin. Well, it could be it's related, but it may be that the elevation of the orexin levels may be, I would say, a compensatory response to the depression, and maybe the lowering of the monoamines or lowering of the serotonin levels that may already be in these patients. In humans, in the plasma, this is in bipolar disorder, you can also see that there's an elevation at least in this study, of orexin levels in patients with major depressive disorder, and perhaps a little even more in patients with bipolar disorder. Having said that, I reviewed the evidence and it's somewhat mixed. This is a potential hypothesis, but it's mixed. Some studies actually found that the levels of orexin were lower in patients with depression. So it could be because of the reliability of the plasma orexin assay. We don't really think it's very, very good yet. And as I said earlier, it may be that at different degrees, different times of the disorder, this could be a compensatory increase that's associated with a sleep and wake disturbance as well. What about anxiety? I just want to remind you that the projections of these orexin neurons to all these areas that regulate stress, anxiety, and mood. So there are, again, several studies that show that there's increased orexin in plasma in patients with anxiety. And this is in this particular study is in adolescents. So they looked at serum levels of orexin A, orexin 1, and they were significantly higher in these individuals compared to control group after controlling for what they could, age, sex, and depression levels. And there was a positive correlation also in this study between trait anxiety, orexin A was found, and also the higher orexin levels. Again, could be not related to the disease itself, but related to the commonality of having insomnia in these conditions, or as anytime you have elevation of the monoamines, you may actually have also elevation of the other wake-promoting agents. Substance use and addiction, I think this is a very interesting area that has a lot of potential, especially because we've had very few medications that can actually, or that we think are safely to treat patients who have either history of addiction or who we are trying to withdraw them or to taper them off of these. So there is opioid withdrawal can increase orexin levels. Again, I think this is a compensatory mechanism. This is it's a response to that rather than that it itself is the issue. However, how many of you take care of patients with narcolepsy? Not many, but some of the neurologists out there. Well, narcoleptics, they have low orexin levels, right? Or you can give them all the stimulants you want. They don't get addicted because they have low orexin levels and because it affects nucleus accumbens as well. So this is a study on alcohol dependence and treated for relapse prevention. It's a small study. And I'm sorry, it's very light there. What you can see here is that in those patients who have alcohol dependence and they're going through, through the relapse period, and they're trying to prevent the relapse, they have higher orexin levels as well. And so potentially an orexin targets for insomnia may be useful in this population, in substance use population, and also perhaps in the use of the relapse prevention because you're treating the insomnia in these individuals. Insomnia is a common part. I'm not a psychiatrist, so I apologize, but it is a common symptom of that we see. And if you have insomnia, you're also more likely to relapse. The strongest scientific data, in my opinion, is in the neurodegenerative disorders. This comes from the WASH group, David Hostman's group, where they show in mice that orexin overexpression is associated with increase in A-beta amyloid and tau accumulation. And also, importantly, when you treat these animals with an orexin antagonist, in this case, it was suvorexin, it was not lemborexin, it decreased the CSF levels of these molecules. So it does seem that there may be a role for orexin antagonists. And indeed, there were 2 studies done in humans, in people with Alzheimer's disease who also had sleep-wake dysfunction. One with suvorexin and one with lemborexin, showing that it can, of course, improve sleep in these populations as well. The data of orexin in humans is a little bit stronger because it's taken from the CSF rather than the plasma. And here Liguori shows that in patients with Alzheimer's, especially earlier Alzheimer's, mild to moderate Alzheimer's, that there is an elevation in the CSF levels of orexin. Now, little data in Parkinson's disease, not a whole lot, but you can again see the same trend that there in plasma, that there's an elevation of orexin in some patients with Parkinson's. Data is again quite mixed, so I'm just making a hypothetical point here. But what I want you to look at is in the second part in B, in the panel B, where it says you can see the level, the severity of Parkinson's disease, right? The severity of the disease. You can see elevation in the mild and the moderate. And when you get to the severe patients, it's low, okay? It's low. So that's, I think, speaks more to that it is part of a reaction to the disease rather than necessarily part of the pathobiology of the disease. Now let's talk about insomnia. I know this is a bit of a review, so I'll go very quickly. It is a disorder in its own right. There is no, at least in the US, we never talk about primary insomnia or secondary insomnia since 2003. And the reason is because it is so often comorbid with medical, neurological, psychiatric conditions. 50% of insomnia is, but it doesn't mean it's due to, because we know that when we treat depression, you can still have insomnia, okay? And we know that insomnia is a risk factor for the development of depression many years later. So we are going to be more impartial. We'll call it, it's a disorder in its own right, but it's often comorbid, and it requires a certain amount of frequency as well as time. It's very important that we look at the symptoms of these patients. They have difficulty falling asleep, difficulty maintaining sleep, or just purely dissatisfaction with their sleep. I don't know what you do with that, but that qualifies as a diagnostic criteria, but it must be accompanied by impairment of daytime function. So if a patient says, doctor, I'm only getting 5.5 hours of sleep, I feel great, nothing is happening, I am the CEO of my company, life is really good, I am thin, I am muscular, everything is good, I would say that this person does not have insomnia disorder. They may have short sleep duration, but they do not have insomnia as a disorder. It is a 24-hour disorder. In sleep medicine, we focus on sleep. That's what's called sleep medicine. It's going to be changed to sleep-wake medicine because we don't consider the daytime symptoms, the daytime issues, and which are very, very important. What you do lifestyle-wise during the day, light exposure during the day, exercise, that all affects your sleep homeostasis. And so I think it's really important to ask your patients about what are they doing during the day, not what they're doing just before bedtime as things that you can treat. I will not be speaking about this very, very important topic because of time, but the first line treatment for insomnia disorder in the United States and really across most of the world is cognitive behavior therapy. Happens to me when I'm sleep deprived. I get this GERD stuff. So cognitive behavior therapy should be used as a first-line therapy or as a adjunctive therapy to pharmacotherapy. I would say actually pharmacotherapy should be used as adjunctive therapy to cognitive behavior therapy. Now, this usually requires training in people that are usually done by psychologists and social workers in the United States. But there are also online versions of this. You can take your patients and ask them to get this online through the website, and there are apps. One of the apps that I recommend is called CBT Coach. It's produced by the Veterans Administration in the United States, and it's free. And it's a very good one to get started with. So having said that, everything I'm going to talk about, when you talk about treatment, assume that have already done cognitive behavior therapy, or I'm doing it together before or with pharmacotherapy. So let's talk about pharmacological therapy. We want to, of course, improve the sleep abnormalities. We also want to improve daytime function. So it's very important to think about that and then minimize the side effects. We've had always, for a long, long time, very efficacious drugs, maybe not for the long term, but we certainly, what we've gained, I think, in the last 5 or so years with this new mechanism is safety in our patients. This is a very large study. I mean, it's not a large study, but the study involved a large number of participants from 36 interventions that were placebo-controlled. And you see the forest plots here. And the first one is showing the efficacy of these compounds for sleep at 4 weeks and then at 3 months. So if you look at the 4 weeks first, you can see everything, every drug that's used for sleep is effective, is efficacious, except for the very bottom here, melatonin, Ramelteon, and even they are efficacious. They're just less efficacious. They're still on the other side, the favors drug. But now if you look at the 3-month or more data, so this is a study that placebo-controlled 3 months or more, you see that there's only 2 here. That's azopiclone, because it has a longer half-life than, let's say, zolpidem. It's not the mechanism. And you have here lemborexin. I'm curious as to why suvorexin. Maybe they did not do the long-term study, possibly. But I would think that many of the DORAs would do the same thing. What about safety? Well, look at imipramine, the benzodiazepines, the Z drug, zopiclone, etc. They actually favor the placebo. So their side effect profile was not good. It favored the placebo. Whereas if you look then at the DORAs here, it did all these other agents, including the DORAs, showed no statistical significant difference from that of placebo. So they're safer. Their safety profile is better. And then in the same study, when they pulled all this data together, they concluded that balancing the long-term efficacy, not the short-term efficacy, long-term efficacy, tolerability of the medication, and safety, lemborexin was the most favorable in this entire group, because azopiclone was efficacious for long-term, but because of the concerns for safety profile. So let's now talk, just review again about the orexin system, in particular about lemborexin as a DORA. It's the only DORA that you have here in India. In the United States, we have 3 DORAs, and they differ a little bit from each other. So it is thought that there's hyperactivity of the orexin system in patients with insomnia. So this is hypothetical. This is theoretical. And that therefore antagonizing the orexin system could dampen this hyperarousal in these individuals. So that's the premise. And with that comes really, since only about 5 or 6 years ago, this has been the only new mechanism of action of any hypnotic medication. So it is not to sedate the individual, but rather to decrease wakefulness, decrease the hyperarousal. So it's a different way of looking at it, and both actually, of course, end up with sleep. I'm not going to go through this very much, except to say that if you look at the orexin receptor antagonists like lemborexin and studied in vitro, it does not bind to GABA, does not bind to serotonin, adrenaline, noradrenaline, histamine. So to many of these neurotransmitters that we actually target in many of our comorbid conditions. So the receptors are very, very selective it's selective, and it may be influencing some of the safety profile that we see. There were 2 major pivotal studies with lemborexin. They were called Sunrise 1 and Sunrise 2. And I will not be giving you the data itself, but just to summarize, it was effective for sleep onset. And it was very brave, I think, of EISAI to actually compare it to zolpidem. Very few trials compare it to an active comparator. And so it did. It decreased sleep latency by more than about about 25 minutes, so people are able to fall asleep within 25 minutes. Insomnia patients is 30 minutes or longer. It also improves sleep maintenance as measured by wake after sleep onset, both objectively with the EEG and self-reported measures by the patient, again, compared to placebo and also with zolpidem. It also improved daytime fatigue. We talked about how important the daytime symptoms are, and very few studies, even with the Z drugs, actually looked at daytime symptoms. So this is a new thing with all hypnotic medications, that they'll be looking very carefully at daytime symptoms. It also decreased the insomnia severity index at 12 months. Here, I only want to show you this data. This is the 30-day data, 28 to 30-day data. Placebo, zolpidem, the 5 and 10 milligrams for sleep latency. You can see it decreased the time to fall asleep. But if you look carefully at the blue and the kind of the purple, you see they're pretty close together, the 5 and 10 milligrams. So not a huge difference. So I think we should all start with the 5 milligrams until we need to titrate up. You see, the difference is not, they almost overlap at the end of that month period. For sleep efficiency, you have something similar, but you see a little bit more of a difference between the 5 and 10 milligrams. And this is the study, this is 12-month study, 6 months of placebo controlled. And then these individuals were able, if they got the placebo, to then go into the arm of the treatment arm. And this is the 5 and 10 milligrams. And just to show that it was effective and it continued to be effective for the entire 12 months. Somebody asked me, how long can you use it? I go, I don't know, I guess for 12 months, because there's data for that. For longer, we don't have the data. Well, we have non-placebo control data. We do not have for safety standpoint, but we don't have efficacy data. Daytime symptoms, no effect on next morning residual effects on cognitive functioning for lemborexin. The same thing, lemborexin caused less middle of the night balance problems compared to the Z drugs. And also there was no significant difference from placebo in the driving performance with lemborexin. I'll show you just very quickly the balance study. You can see here, it was compared to zolpidem in the light purple, and both the lemborexin 5 and 10, you can see that there was some effect on balance, but certainly not as severe or not as prominent as that you see in with zolpidem. Driving performance is very similar. It shows you that they're compared to, not compared, whereas if you look at driving performance for zolpidem, which you actually have in this country, and flunitrazepam, which is benzo, and rameltan, they impair driving performance statistically significantly, whereas lemborexin had no clinically significant difference in lane deviation, the standard deviation of lane deviation. So are there then insomnia subtypes that you may be more likely benefit? So you're in the clinic and you're like going, I can do a Z drug, they're effective. I can do an antidepressant, for example, if I have comorbid, depression, maybe something like mirtazapine, et cetera. So are there anything that, this is my thoughts. So thinking about the role of orexin maintaining the stability of wake, maintaining the stability of sleep, and the hyperarousal component, I think patients with hyperarousal, they're clearly hyperaroused. They're not sleepy people. They can't sleep even during the day, okay? They can't even take naps. That group needs to dampen down there a little bit. Also, as a circadian person, I think that shift workers, because the homeostat is high, but the circadian drive is misaligned. And so you may want to dampen that down a little bit. It could be useful. Based on the inputs and outputs of the orexin neurons, I think patients with insomnia, with comorbid stress or anxiety, arousal in the setting of reward, substance use and substance abuse, that could be a medication that could be used more safely in this population because there was just no abuse potential liability with this medication. And then in the future, thinking about patients with neurodegeneration, older adults with falls you are concerned about, and also the cognitive issues. So from the safety profile. So very quickly, I will go on the two cases if I have time. I think I do. So first is a 65-year-old female who has difficulty falling asleep and staying asleep for several years now. And it's become really much more severe for the past 8 months. She's a little bit overweight in the US, that's just a little bit overweight. She takes about 1 to 2 hours to fall asleep and wakes up 3 to 4 times during the night. Can't shut her brain down at bedtime either. She has a history of anxiety and depression that's treated pretty successfully with sertraline, and she has common migraine. Recently was diagnosed with possible mild cognitive impairment because she was having difficulty with her memory. She's also noticed that she has to get up 2 times to go to the bathroom, so there's a bit of nocturia here. She had a sleep study, which anybody with nocturia should get a sleep study because it could be OSA doing that. So she had a sleep study, so very mild sleep apnea. She chose not to be treated for that. When she came to me, she was taking Zolpidem. When she came to me, the history was that she was taking Zolpidem 5 milligrams. Then her PCP changed it over to Zolpidem CR 6.25 milligrams. And she still was having trouble staying asleep. So the PCP says, I'm not going to increase this. I don't know what to do. Go and see one of the sleep specialists. And so she was worried when I saw her. She says, I am so afraid that I'm not sleeping. I'm so anxious because I hear that I'm going to get Alzheimer's disease because sleep disruption is a risk factor for Alzheimer's disease. So you have to calm your patients down and go, well, you don't have it. It's okay. We can help you sleep. But this is the data. It's very strong data that sleep fragmentation is a very significant risk factor for the development of cognitive impairment and also Alzheimer's disease. She also has depression, and insomnia could be part of her depression because she also, you can see that depression, insomnia is a risk factor for depression as well, even years later. Now, I want you to just think about this patient a little bit. She has daytime function issues, her mood, anxiety, concern about her cognition. She has a memory impairment. She has nocturia. There's concerns about risk of falls. She's an older individual when she gets up to go to the bathroom. And she has mild sleep apnea. So she's taking Zolpidem 6.25 milligrams, not working very well. She needs something for sleep maintenance. So what would you do? Think about it for a second. Well, I continued the sertraline. Why would I? I'm not a psychiatrist and she was working, so I continued the sertraline for depression, anxiety. Did not change that. Did cognitive behavior therapy. And that means looking at sleep hygiene, looking at lifestyle things that you could intervene with almost immediately, and not only medications. Medications, it's an adjunctive therapy. So I did a DORA trial because of what I just told you, because it can help people with sleep onset as well as maintenance insomnia. Had a favorable safety profile. Of course, there are still safety issues with lemborexant, but there's favorable safety profile. And then the question is, are you going to switch or are you going to taper this medication for Zolpidem? It's all correct. Whatever you said is correct. This is a study done by EISAI, and they transitioned because they thought this would be a question that people would have. So they actually did the study. There was 3 cohorts, people who were taking Zolpidem intermittently, people who were taking Zolpidem more frequently, and then there was the 5 and the 10 milligram lemborexant. So what they did was there was no taper. They just stopped. It was a switch study. They stopped the Zolpidem, and I'm not going to show you this. And what they found was that 80% successfully transitioned to lemborexant, intermittent or frequent, without tapering. At the end of the treatment period, more patients on lemborexant said that it helped them fall back to sleep. Remember, they were all at one point on Zolpidem. So they were comparing what they're taking with lemborexant without zolpidem. And the safety profile, please take a look at the prescribing information was as you would expect for lemborexant. Another study, a more real life study, I suppose, in the clinic, this group took patients who are in Z drugs on monotherapy, patients who are in suvorexant, which is another DORA, and whether it was not working, that they needed to change or switch, or suvorexant in combination with something else, with a BZRA, for example, and then Rameltan with the BZRA. So what they did with the benzodiazepine receptor agonist was that they actually did taper that a little bit, and then they cross taper it as they were starting the lemborexant 5, and then they went up to 10 milligrams if needed. Their primary outcome was transition to lemborexant at 2 weeks into the maintenance phase. Okay? And again, they show a very high transition rate to lemborexant from any of these combinations of medications. So now with that in mind, let's look at sleepless patient number 2. He's a 52-year-old male with difficulty falling asleep for the past 3 years, and more recently also staying asleep. For falling asleep, he used to take zolpidem 5 milligrams, and that was okay. But really, remember, in the last 3 years, he's been having trouble staying asleep, and much more so lately. So his primary care doctor increased it 5 milligrams to 10 milligrams of zolpidem, which makes sense, to help him stay asleep. He stays in bed for 8 hours, which is too much. So cognitive behavior therapy, bedtime restriction, I restricted his time in bed a little bit by about 2 hours. Not terrible, because I want to build the homeostasis. I don't want him to lay in bed for that long period of time. Psychologically, there's also this issue of anxiety and so forth. So with zolpidem, 10 milligrams, he falls asleep in less than 1 hour, but still wakes up 2 to 3 hours per night. Takes him about 30 minutes to 1 hour to fall back to sleep. Still better than before, than the 5 milligram. So his PCP said, okay, I'm going to add 50 milligrams of trazodone now. And in the US, we call this vitamin T, because primary care doctors really like to use trazodone. And because it's not scheduled, right? It's not a scheduled medication. Didn't really work very well. Increased it to 100 milligrams to maintain sleep. The patient is a CO. He says, no, it's affecting my memory, affecting my mood. I feel kind of drawn out during the day with 100 milligrams. It's helping me stay asleep a little bit better. Was not happy, and then came to see us. The other thing was he has a history of alcohol abuse. Stopped with therapy about 4 years ago. He's been very stable, no relapse at all, but it's a consideration. So here we are, somebody with history of substance use. He then tells me he's using melatonin sometimes as well. And he's on both a BZRA or a Z drug and trazodone. So what do you think? What would you do for this patient? Well, some of the considerations would be cognitive behavior therapy. We definitely want to do that. Could do a trial of DORA, let's say lemborexant. As we said, favorable safety profile from abuse liability, right? So we had some concerns of if we put him on a Z drug or benzo or something, that maybe he will get back into this, not abuse it, but the addiction issue. Now, do we want to switch like they did with the EISAI study? Do we want to kind of switch and taper like they did with this clinical study? Or cross taper, so basically add the medication and taper down the other ones. What are you going to do with trazodone? Should we taper trazodone? Should we leave the trazodone? Should we just decrease the trazodone? And then some patients that I have, they are very scared when you say, I'm going to stop your medication, or I'm going to taper down. They still want, although the zolpidem wasn't really working, they still want that at their bedside. It's just in case. So do you prescribe a little bit of that, or as we call a rescue medication? So here are your choices, or there may be more choices, but these are the ones I came up with. You can stop the zolpidem, you can continue trazodone, and you can add lemborexant 5 milligrams, and you can titrate up to 10 as needed after 2 or 3 weeks. Another choice, you could stop both zolpidem and trazodone. You can just do the switch thing, but remember, you're not supposed to stop these antidepressants abruptly. So I would say I would probably not have chosen to stop the trazodone. Then you add the lemborexin and then titrate. You could first then say, I'm going to taper the zolpidem and I'm going to keep the trazodone, and then add the lemborexin. Or you can say, I'm going to taper the zolpidem and I'm going to taper the trazodone at the same time as well, and then titrate up to 10 milligrams if needed. Okay. So this is what I did. I'm sure you're all thinking like, what would you do? But this is what I did. I tapered off the zolpidem 2 to 3 weeks. Immediately what I do is I cut everything in half. I don't know why. I just cut everything in half. If they're on 10 milligrams, I go to 5 milligrams. They do great on 5 milligrams. And they don't get very anxious about that. And I did start LEM 5 milligrams, but I also tapered the trazodone from 100 to 50, and very slowly the 50 down to 25. There's some, because I was concerned about the sedation of trazodone having a fairly long half-life. And then the patient may think it's because the DORA is not working and he's got sedation. So I wanted to minimize that sedation as much as possible. And of course, the rate of tapering and stopping depends on the symptoms. It could take only 1 to 2 months, or it could take 6 months, sometimes a whole year, to get people off of it. And I did give him a little bit of zolpidem in case he needed it. And the good news, he never used it, but he always has it on his bedside, the zolpidem, just in case, but he never used it during this period of time. So CBT is very important. There was a consensus recommendations about discontinuing or switching or deprescribing insomnia medications. I just want to highlight a couple things. If you are on a DORA, no need to taper the DORA. If you're going to stop the DORA, there's no need to taper the DORA or doxepin or Romaltian. The antidepressants, however, and antipsychotics are used to treat insomnia should be gradually reduced when discontinuing and with administration of another hypnotic. So I think I did the right thing here. And cross-tapering is recommended for benzodiazepines and Z-drugs when you are adding another medication. So that's what we did. We cross-tapered. And very importantly, please, before you even switch or add, think about the drug-to-drug interactions that are of your patients who are already perhaps on many medications that are also, for example, metabolized by the liver. And that could change. So this is indeed a time, I think, of precision medicine for insomnia. We're beginning to really get there, that insomnia is often comorbid with medical and psychiatric conditions, and also other sleep disorders, restless legs, OSA. 40% of patients with OSA have insomnia. And a patient with insomnia can also have OSA. So we always need to screen for other sleep disorders in these patients. The insomnia subtypes, we now have many other options on the market that we can use. Sleep onset insomnia, sleep maintenance insomnia, both types of insomnia, and also safety of these medications. I want to also stress lifestyle and behavior, very important part of any treatment of any patient with insomnia. And we need to ask about their behavior. We need to ask about how much light are they getting in the evening? How late do they eat in the evening? What do they exercise? Do they have regular schedules? All of this is going to be very, very important. Are they getting enough light during the day? Because that can help you with your circadian system, but also with your sleep. And then, of course, consider pharmacotherapy. Mealtime has become a very big thing in the US, and we use it very frequently. And I'm quite happy about how that itself can help people sleep better. So the goals are into balancing efficacy and safety always, I think, in any of your patients. And finally, of course, we want to improve sleep quality, but we want to improve daytime functioning. But I think for the future, where I'm excited about is, can we also improve the comorbid conditions that exist with insomnia, and or treating sleep? Could we maybe alter the expression and sequelae of some of the comorbid conditions that we have. And we have some data in depression, actually, that may be the case. So I think mechanism does matter, particularly for safety and also for efficacy. And the DORAs are effective for both of these things. And also some food for thought that when you think about all these multiple other CNS regions that have orexin receptors, the projections of the orexin system, that we do need to have studies, real data, real multi-center studies to ascertain the effectiveness, but also the safety of DORAs in insomnia that's comorbid with these neurological, psychiatric, and metabolic disorders. We think it would be, it's good. However, it may be different once you actually do these types of studies. And especially because 50% or more of patients with insomnia disorder, maybe a disorder in its own right, but is comorbid with these conditions. So I think it's really, really important, especially something like what they did with lemborexin and Alzheimer's disease. We need to do lemborexin with, let's say, depression and some of these other conditions as well. So given that, I think it's in the future, we can look at the relationship of the orexin system with neuropsychiatric disorders, whether you're looking at agonists or antagonists. And what I did not have time to talk about was the role of orexin in blood pressure, autonomic regulation, which is going to be very, very important, because I think that's what it's working. Any time that there's high sympathetic activation, I think the orexin antagonist can help dampen them down. And then also in the management of weight and metabolic disorders, there's data that's evolving also in that area. So I want to end by saying that sleep is a health imperative. It is not that it's only comorbid. We have plenty of data now to show that it is a risk factor, early risk factor, maybe the earliest biomarker for dementia, early biomarker for dementia, maybe early biomarker, not insomnia itself, for Parkinson's disease like RBD, REM behavior disorder. So I think this is a really, really fun area, especially for you younger doctors out there. The future is quite bright for this. This is a study that we did. It was published in Lancet, and we were looking at how much data is there in the world about just one aspect of sleep duration, right? So in the blue is where there's a lot of data, but there's data that's also for the general population. And in the green is where India is. You have data in special populations. For example, let's say in shift workers, for example, but you don't have it yet for a general population across India. So something that sleep enthusiasts, you may want to promote something like this to the government to be able to do an assay. What is the sleep duration here across India, across various regions of India? So very much thank you. I really appreciate that you came here on this Sunday evening. Okay, good. Yeah. No, if that happens because I get discouraged.
Clinical practice. Today we have a very eminent psychiatrist who is a psychopharmacologist we can call Pitamaha of psychopharmacology in India, Dr. Chitranjan, ready to come over with the chairperson of this program. Yeah, please. We have other eminent panelists who are psychiatrists and neurologists. I request Dr. Vinod Kumar, Dr. P.T. Shukumar, Professor of Psychiatry, Dr. Vinod Kumar, a practicing psychiatrist and a psychotherapist who practices in East and West, night at England, day in India. And now I have two eminent neurologists, Dr. Divya and Dr. Shukumar. Both are products of Sri Chitra and we will have a small discussion. How do we translate what we learned theoretically into our practice? And I will also encourage all the participants to ask questions. Thank you. Start with, this is a question to Dr. Feliz. Madam, in India, see today, though these orexin receptors are spread over three specialities, psychiatry, neurology, and cardiometabolic disorders, but we will be focusing today on only neurology and psychological disorders. One of the things we come across is in Indian context, a lot of elderly people who have visited the cardiologist or a physician come back with a small dose of alprazolam or short-acting benzodiazepines for a long time, a decade, 10. Some of them, as they grow older, would like to increase the dosage. Can we shift such patients, for example, 0.25 to 0.5 milligram, straight to orexin receptor, or do we need to taper and do it?
I think you should, unless you're on alprazolam like 0.25 milligrams, you probably don't need to taper it. But usually the recommendation from the consensus statement was to taper benzodiazepines, taper also the Z drugs.
Even if it's a small dose, we need to taper and switch it.
Psychological dependence on this, and so I would do it. And I have patients who take 8.5 of alprazolam, they cut it. Sometimes they even just like take a little powder of it.
Thank
They
you.
think it helps. So I let them do that as long as they keep it off.
Thank you, madam. So insomnia, orexin system, and treatment with DORAs, as madam has extensively explained, but there are two disorders, especially in neurology, are of great interest. One is sleep-wake cycle disturbance and insomnia in Alzheimer's disease. Now, the first question to my friend Dr. Shivkumar. Dr. Shivkumar, you keep seeing a lot of Alzheimer patients. I guess most of our psychiatrists also agree, especially when the disease progresses, especially when they reach a state where they have behavioral and psychological symptoms associated with dementia. One of the main complaints from family members and carers is, doctor, when we sleep, the patient wakes up and disturbs, and when we are working, the patient is asleep. How do you manage?
Thank you, sir. And it's a very difficult problem for us to manage in Alzheimer's disease, particularly when they come to us with probably an worsening of the disease with some medical problems. So their sleep is disturbed. They have some hallucinations happening. They sleep in the daytime and they are awake throughout the night. And then they are having a lot of confusions in the daytime with agitation, all those things. So we need a medicine where we have to reverse the sleep-wake cycle, reduce the sundowning, what is happening in them, and probably give a good sleep, which can give as natural sleep as what they sleep in the night. And we don't want a medicine which can have problems in the daytime, like worsening of the cognition, increased risk of falls, or maybe worsening the hallucinations of what the patient has, or interaction with the drugs, what they're already using for multiple comorbidities. So interaction has to be kept in mind whenever we are choosing a drug. So what we have in our basket right now is we use an atypical antipsychotic, one. Sometimes we use melatonin. Then we have a good medicine like lamborexant, which we can use in clinical practice. So we often use lamborexant in a dose of 5 milligram. Try to see that they go back to sleep, keep them active in the daytime, avoid sleep naps, except for a small short naps in the late afternoon after meals. And then we try to see how we can get rid of this crisis. This is what we normally do in the clinical practice.
Say something about the sleep disturbance in Alzheimer's disease is not really classical insomnia. It's what we call irregular sleep-wake rhythm disorder. It's word because it's fragmented. It's fragmented during the day, it's fragmented during the night. So wake is fragmented as well. So it's not kind of the classical one. And it does require, I think I agree, with with this very multimodal approach, but I would also encourage this behavioral, the environmental approach, light therapy, increase light during the day, keep them more awake during the day as much as possible, decrease noise at night if there's decreased noises at night. So it's really kind of a bit holistic way in some ways. And then when you need to, of course, use the medication, and the medication doesn't have to be used every night. It can be used intermittently as well.
Thank you, madam. What you said was some behavior therapy with medication will be beneficial as much as possible. Avoid daytime lying down in the bed. In Indian context, they come and tell, no, doctor, I'm not sleeping, just I am on the bed. And however much we try to convince, they are not convinced. Second is not seeing the light, bright sunlight. So probably that's what madam tried to highlight. Similarly, Dr. P.T. Shukumar, you are working in this area, you will see more of PPSDs also, behavioral and psychological symptoms associated with dementia. Because theoretically, starting DORA at the early stage of MCI, probably our initial insomnia, which can be a part of early dementia, as Dr. Felici said, we may have to start on lamborexant. But in your practice, where patients will come to you when all the symptoms have exacerbated, and one of the main problem is insomnia, how do you manage in your clinical practice?
Thank you very much, sir. So I think being in institution like NIMANS, we see more severe spectrum of behavioral and psychological symptoms. And when we see people with severe agitation and aggression, I think we use other behavioral management, and a lot of times we have to kind of de-prescribe some of the medications. Sometimes they will be on, its iatrogenic effect is something very, very important. And the other, I think during that time, antipsychotics do help if particularly agitation is very severe. And when we use these medications, the challenge is often the balance is very difficult because in people, most of the drugs, the tolerability is a challenge. So if we do get people who have, say, behavioral symptoms at an earlier stage where it is not that problematic, where insomnia or sleep is the primary issue. And during that time, I think the options like lemborexant can be helpful. But when it is the severe side, we try either antidepressants like mirtazapine if there is a lot of emotional symptoms. And trazodone is again something which it is very helpful. But if they are able to tolerate that, the daytime sleepiness is one of the challenge. If sometimes even a small dose people don't tolerate, and then daytime sleepiness becomes excessive. Antipsychotics, quetiapine, we use more quetiapine because of Parkinson's risks, and with that, I think a lot of behavioral management and as whatever already has been highlighted, the daytime activities and cutting down the iatrogenic effects do help.
Thank you. In Indian context, especially in male patients, elderly, also have many medical comorbid conditions. The commonest is uncontrolled diabetes and BPI, benign prostatic hypertrophy. So these are the patients with early dementia or insomnia would like to wake up in the middle of the night. And that is the biggest challenge. So anybody from audience can address this. What's the drug of choice? A 75 years gentleman walks into a clinic, probably MCI we have just recognized, and having so many medical comorbid conditions. However much we try to control his diabetes or any other condition, he has to wake up in the middle of the night. What's the drug of choice? Anybody? Why I'm asking this is, whenever such patient comes with such symptoms, we are always tempted to give them a sedative. Only one thing we should remember: when they wake up in the night, there are two issues. One, any muscle relaxant should not make them to fall and sustain injuries. Second, when they wake up for their nature call, whatever, again, they should get back to sleep. So this is the biggest challenge in the geriatric population we see in our practice. Probably here, lamborexant fits into it because this is one drug which gives adequate sleep, but when they wake up in the middle of the night, the risk of fall is less, as well as getting back to sleep after waking up is also less time. I think our panelists will agree with me. Thank you. Now, Dr. Vinod, No, in psychiatric practice, one of the commonest symptom is majority of our psychiatric patients have insomnia. Dr. In the madam has highlighted in her presentation how in all the psychiatric conditions, whereas anxiety, depression, schizophrenia, bipolar, depression, all have insomnia. I'll just try to request you to see how do you manage a patient with anxiety disorder having severe insomnia, because 70 to 80% patients will have, especially in GAD, panic disorder, have insomnia. How do you manage in your practice?
So, I mean, this is a very interesting question, sir. So, what I've seen over the years in India, ma'am, there's a lot of usage of benzodiazepines, primarily clonazepam. It's just part of the whole sort of, pharmacotherapy, options we have. And I've always, for some reason, I trained in England and I lived there for a long time. I've been against that practice. And I think it's pertinent in our country that we do not promote this anymore because there's a lack of control of availability, in most parts of the country. And it's a problem. You actually introduce a benzodiazepine to a neurotic individual, it's like, a tiger tasting blood, ma'am. And that's been my stance for a long time. And it's time for us to stop doing that. And, I think if we think deeply, it's something which needs to be done now. So for management of anxiety, sir, to go back to the question moderator sir asked, I think anxiety is a symptom of a variety of psychiatric and neuropsychiatric disorders, and you do not just treat symptoms, and that's not what we should do, right? We should be looking at what is causing that anxiety primarily and try and address that at the core of it. So, if you have to educate a patient that if depression is causing anxiety, or if there is neurodivergent sort of obsessive tendencies that is causing anxiety, then you first of all get the diagnostic clarity. You educate. You do CBT-based interventions. You give the right medications to treat the core psychiatric issue. And see, that's not an instant response, and that's where I think a lot of our busy clinicians are unable to sort of, fully do justice to the treatment process. But I think we should all try. It's really important. I think what has happened, sir, is that, if you go back in the 60s, 70s, a physician would just say, you've got fever, sir. You take some paracetamol. That's not the way to look at things, of course. Yeah.
What I would like to ask the madam is one question. Patient has been started with, as he said, SSRI, SNRI, any other drug to start with for anxiety, PTSD, all the GAD, generalized anxiety disorder, panic attacks, etc. But initially patients would like to have a comfortable sleep as well as anxiolytic to come down. So benzodiazepines started. Once after some time when the drug takes over SSRI or SNRI, we would like to withdraw gradually the benzodiazepines. In such patients, are there any studies to tell DORA can replace just for sleep and we can continue to maintain SSRI or SNRI?
Oh, there are no studies specifically addressing that, but if you look at the study with, the clinical study, there's some indication that yes, you can do that, but you should taper the benzodiazepine or the BZRA or the Z drug. So yes, it's potentially. I just want to make a point that I don't want people to think that the lemborexin or DORA is treating the depression or the anxiety. We talk so much about it. I think you made a very good point. It needs treatment, either behavioral or looking at what's going on or other medication. But it's a good one to add to the armamentarium because it's less likely to interact also from a mechanism standpoint with these other medications.
Dr. Andrade, Chitranjan, apart from this, what is your suggestion at the end of 12 weeks patient has improved with a combination of SSRI, SNRI with either benzodiazepine, one of them, and we would like to withdraw. Still patient has insomnia. What's your take on this? Whatever it is, scientific.
The first point that I'd like to make is that we sometimes do need to prescribe a benzodiazepine along with an SSRI and SNRI when treating major depressive disorder, if only because patients with MDD often have very severe comorbid anxiety or even agitation.
Yes.
And B, the introduction of an SSRI or an SNRI can be accompanied by serotonergic symptoms in the initial couple of weeks, which are associated with akathisia or associated with heightened anxiety, the jitteriness syndrome in the initial couple of weeks of treatment. And benzodiazepine is probably one of the best concurrent medications to be prescribed along with the SSRI or SNRI for these symptoms. Having said so, we should realize that we don't need to continue with benzodiazepine forever. Once the patient becomes better, the depression starts improving, the patient stabilizes on the antidepressant, we don't need to continue with benzodiazepine. I prefer clonazepam because it's an intermediate duration benzodiazepine. It has a half-life of about 34 hours. It is less habit forming. I would never prescribe alprazolam. I haven't prescribed alprazolam for 25 years and it will not start. Similarly, I would not prescribe lorazepam. Alprazolam has a half-life of 5 to 15 hours. Lorazepam has a half-life of 8 to 18 hours. I would favor clonazepam, which has a half-life of about 34 hours or thereabouts. And once the patient is stable, I would taper the clonazepam. And in the vast majority of patients, I do not see a problem. So I would not need to introduce any other hypnotic agent to replace the clonazepam. The patient is able to come off the clonazepam. If the patient has difficulties, till now, what I've been using is a low dose of a tricyclic antidepressant, something like 25 to 50 milligrams of dothipin as an example, or 25 milligrams, 10 to 25 milligrams of amitriptyline. Since we are at the lemborexant program over here, lemborexant is an option for patients who have insomnia afterwards.
Thank you. Another major neurological disorder where they come between psychiatrist and neurologist, Parkinson disease. When we find some Parkinson disease patients in the initial phase, we refer them to a neurologist. When the symptoms worsen and they get back with two reasons. One, associated psychological symptoms, or drug-induced psychological symptoms. Again, their insomnia is a big challenge. I have this question to Dr. Divya. A lot of patients with early Parkinson's disease have insomnia. How would you like to manage along with your replacement therapy? Levodopa.
So we know sleep disorders are very much associated with Parkinson's disease, especially early on as well as during the course of the disease. So especially when you're talking about a person who has severe Parkinson's disease, one of the most important things to rule out is whether the disease itself is well controlled. Because a patient who is, most of them have a nocturnal echinacea, which is maximally contributing to the insomnia or the sleeplessness. So the first and foremost thing to be addressed is definitely whether they have a nocturnal echinacea. So you give a night dose of levodopa and adjust that. Now, if despite you ask them whether there's a difficulty in turning around in bed, so just giving a hypnotic agent does not help them. So if you give a night dose of levodopa and once you are sure that it is not the nocturnal echinacea, then you can add a hypnotic. So if they, usually what we do is if there is a associated REM behavioral disorder, which is very commonly present, in that case, we prefer clonazepam or a benzodiazepine, of which clonazepam is one of our usual go-to drug. Now, if there is, they are on clonazepam and they are not improving, or if there is no REM behavioral disorder, so we have started multiple patients on DORA and we have found that they have a significant improvement in the sleep quality as well as efficiency. That is, they feel that they are better off during the daytime. Many of them better than clonazepam, in fact, during the daytime. So definitely you have options. And one of the other things that has to be looked into is many of the drugs which are associated. There are many other sedative drugs which are given during the day, which is altering their sleep cycle. So what is happening with the other drugs? So we need to look into the pharmacology of that, and that's always one of the most important things. And when a patient presents to us with an acute insomnia or suddenly there's a reduction in sleep, you also have to rule out, like sir has already mentioned, metabolic infections, urinary tract infections are very common. Just at the onset, you start with an insomnia and then they go in for a psychosis. So drugs, metabolic conditions, the disease itself, And once you address that, and then I would go for treating with the hypnotic, because that comes first. Otherwise, just starting a benzodiazepine or any other hypnotic would not do the job. So we always have to go in that order, and that should be the rule to go to.
If you are using lamborexant, what's the starting dose and what's the maximum dose for our audience sake?
So generally with lamborexant, we always start with 5 mg. I have started with 5 mg, and most of the patients have tolerated that. Very infrequently, we do see patients, they come back and tell you that I could not tolerate 5 mg, especially who are elderly, like more than 65 years. In that case, I have, because they don't, some people don't require a daily dose as well. So there are cases where we have given alternate day, and sometimes we ask them to take half a dose, and maybe intermittently also. Some patients, after taking 2 or 3 days, they feel that their sleep quality is better, and they themselves make it intermittent. So if that gives them a good quality of sleep, that's fair enough to tell them you can use that, because they are already on multiple medications. But most of them at 5 mg, they do well. And if they feel that they get a sleep but then it's not adequate, then maybe 10 mg. But seldom, I mean, we do go to 10 mg. Most often with 5, they're fine.
Thank you. Similarly,
ask
yes.
about the treatment of RBD, or REM behavior disorder. In the US, our first line is high dose melatonin. It's not clonazepam. Well, it's very effective. Clonazepam is very effective because so often comorbid with sleep apnea. So that's why we choose the melatonin. We start at 3 milligrams and we go up as high as 12 milligrams. I don't know why we need such high doses, but that's the first one.
Yeah, just as you mentioned, we have found that melatonin does not work as well for Parkinson's disease. For some odd reason, at 3, at 6, we don't really get that effect what we get with 0.25 of clonazepam. So many a time we start and then we come back to clonazepam.
Use a little bit of both.
Yeah, and especially when we have restless leg syndrome associated, what we have found is, in fact, perimpanel works as a very good drug which modifies restless leg as well as sleep quality. So that's another, especially in epilepsy as well as patients with restless leg. Perimpanel has been used as a drug to improve the sleep quality. What are your, like, we have not talked about.
Agree, no, absolutely.
One comment from my side. So particularly if someone is on dopamine agonist like pramipexole and ropinirole, when you're using lamborexant, we should be careful because sleep paralysis is an important problem. Both the drugs can cause sleep paralysis. So we need to be very careful when we are using lamborexant with dopamine agonist. Another drug, what we use for RBD is rivastigmine, is a very good drug, which does not have problems. Can be used as a treatment for RBD if clonazepam or melatonin.
Yeah, can I make a comment, sir? So, ma'am, in your experience with the kind of sleep studies, the polysomnographies, and sir, yourself as well, Chaitanya sir. So, when we use, like in my opinion, when you go to sleep after drinking alcohol, your REM kind of really kind of goes down, and so does your deep sleep. And I think it's true for benzodiazepines as well. What's your thought on that, ma'am?
Benzodiazepines do suppress both REM and slow wave sleep. And so that's part of the issue. Whereas something like some of the, like zolpidem, some of the Z drugs, a little less so. There's a little bit more of that, but the benzos are very strong. They can suppress both of these. Not as bad as the barbiturates. The barbiturates really suppress those, but so there could be some rebound. But I'm not sure that we see as much of that when we stop it. I think it's pretty low levels of that. And some of these, like clonazepam, has a very long half-life. So it may not be an issue. I think the message is that I've been hearing with my colleagues is very important. It's not just about the insomnia. We have to find why, what's going on with the comorbidities, and then decide what treatment is the best treatment. Sometimes it's no treatment. Sometimes it's to stay on the benzo because you need to stay on the benzo. Yeah.
What Dr. Shivkumar said is a learning lesson for us, especially when the patient comes with restless leg syndrome. Pramipexole is the first drug we probably, or gabapentin are the two drugs which we, as psychiatrists, we used to practice. But when they have insomnia, not to use DORA. What's the drug of choice if they have sleeplessness along with this?
I'm not saying not to use, but we need to be more careful. We need to educate the patient. that sleep paralysis can be a symptom which can be observed in DORA very rarely, in maybe 1 to 2% of people, and we should be careful. Second, for restless leg syndrome now, pramipexole or ropinirole is not considered a drug of choice now because of a lot of augmentation of symptoms, what is happening with restless leg syndrome. So normally what we use is we use gabapentin or pregabalin, which is very good, and that can take care. So more than 0.5 or 1 milligram of ropinirole, pramipexole, the risk of augmentation is very high. So we don't use this in clinical practice.
Do you have anacarbonate here?
We don't have.
We don't have.
A lot of
But,
yes,
restless
Dr.
leg
Priya?
syndrome with sleep deprivation, I think perampanel is a wonder drug at 2 mg, and after 4 weeks, if it's still not completely benefited, 2 mg, 4 mg alternate day, that works wonders.
Again, loudly to.
Yeah, so when a patient has restless leg syndrome, as Dr. Shivakumar already mentioned, currently pramipexole and ropinirole at higher doses, we don't prefer as the disease progresses because you have a risk of augmentation. That is, when you have, suppose the patient starts with restless leg at around 6 o'clock, after some time of giving pramipexole, they start developing it earlier. That's called augmentation. That is by 4 o'clock, 2 o'clock. The time starts coming up, or it spreads to other parts of the body. That's called augmentation. So in those cases, that's why dopamine agonist is not the first choice drug currently. So you have other drugs like gabapentin and pregabalin. But definitely, currently, almost as a first choice, we are starting perampanel along with pregabalin and gabapentin, because at 2 mg and sometimes very occasionally at 4 mg, they have a dramatic response to restless leg syndrome with improvement in sleep quality. So currently, I think as with restless leg, the first choice, I would definitely go for perampanel. And especially when you have associated SSRIs that are there, they worsen restless leg syndrome. So we have to be really cautious because RLS can be a really troublesome symptom causing insomnia. So in that case, you have to modify the dose of SSRI. And I think of the lot, vortioxetine is slightly better with respect to restless leg syndrome, because the studies say that vortioxetine is better than other SSRIs. In improving this, in reducing the symptoms of RLS. But when patients have severe depression, I don't know whether it can be controlled with vortioxetine alone. So we'll have to go for other drugs. But when possible, we could probably go with vortioxetine.
Thank you very much. It's an eye-opener for psychiatrists because majority of audience are psychiatrists. Now it's a question to Dr. Felice. But Dr. Felice, now it's for Dr. Felice. There's a question from Chennai, because in the Sunrise 1 and 2, both have mentioned the adverse reaction side effects are less than 10%, but they are worried about somnambulism, then sleep paralysis. What's the percentage and how severe it is for the audience?
In the FDA warnings in the United States, somnambulism or just basically complex behaviors in sleep is in every hypnotic, regardless of its mechanism. Ramelton has the same warning. It was not really a problem. Sleep paralysis 2%, somnambulism not in.
And also it doesn't last longer.
Correct. The sleep paralysis, it can go away after some time, but sometimes it is. I always tell my patients before I start lemborexin or any DORA, I tell them about sleep paralysis so they don't get scared if that happens. I don't have too many patients who actually stopped the lemborexin if it was effective because of the sleep paralysis. It's pretty mild. It's not like people with narcolepsy where they have prolonged sleep paralysis. This is pretty mild in general, but
I think we have at least almost like at least I have 100 patients who are on lemborexant, and I'm yet to see a patient who has had a sleep paralysis.
I've seen
So maybe I'm not being categorical, but like our ICD risk of impulse control disorder risk with pramipexole is quite low as compared to the Western studies. So maybe that our risk of narcolepsy, like narcolepsy is a very rare disease as far as we are concerned. So maybe our risk of sleep paralysis may not be really that high. So we'll have to, we don't have real data on that. But I think most of our patients seldom do develop such a sleep paralysis, or at least we are yet to see one. So maybe we can educate them regarding that, but generally it's a very rare disorder in our population.
vivid dreaming is more common.
One of the questions from other center is, when we use this lamberexant for a year or a long time, what are the red flags one should look for, like any other neuropsychiatric side effects or any other thing to be watched when a patient is on for long term?
Yeah, I don't think there's anything you would look for except when it stops working. If you need higher and higher doses, I have always some concern that I may be missing something. I usually my practice, I would not actually keep somebody on lemborexant or any hypnotic medication for 12 months without trying every 3 months to use cognitive behavior therapy and other methods. I make a deal with my patients at the very beginning. I go, this is good. It could be a benzo, we could start benzo, but the plan is we're gonna taper you off of this, okay? This is great right now, but we're gonna taper you off of this and we're gonna use this and that. You can do it very slowly, as much as you can, but I always try every 3 months. I see my insomnia patients, or maybe every 6 months, depending. And I always talk about, okay, how do you feel? They go like, I'm sleeping great, I'm sleeping very well. I go, maybe now we can start tapering it a little bit. And usually that helps, that works. There are some patients who are on it forever, for like a year, 2 years. But I think we should always try to test to see whether it's still needed.
One of the question is, though you have highlighted in your presentation, sudden discontinuation of lamberexant after a long time, will there be any rebound phenomena or any other side effects?
I don't know that there would be, I don't know about 1 year, the studies were not done with 1 year, but there's no rebound.
No.
And that's why the consensus statement says you do not need to taper Levorex or any of the DORAs.
Is
May I
it-
just add a
tell me.
point? Like most of our patients just come out of lemborexant quite often. And when you ask them on follow-up, are you taking this medication? They say, no, we have already stopped. Our sleep quality is better and it has remained sustained. And then they just come off it. So it's not for you to taper. Even before you decide to taper, they would have gone off it. As compared to benzodiazepines, which they continue despite you telling them not to. Many of them just stop it by themselves. So I think the abuse potential has to be quite low for them to do.
So again, we come back to the one thing. Short-term insomnia, drug of choice can be even Z group. Chronic insomnia, drug of choice is DORA. So sudden stopping or withdrawal, the rebound phenomena and withdrawals are not seen. That is what the studies say, even at the end of 12 months. One more question is it safe to be given for lactating mothers? Because in some of them not amounting to depression, they have insomnia.
Yes, yeah. Or pregnancy, it's not indicated.
Question.
The studies show that there are minimal secretion in breast milk. It's almost nil. It's minimal secretion.
I don't think so. I think it is secreted into breast
is,
milk.
it is.
It is secreted into breast milk,
Not
and
too much.
it shouldn't be given to mothers who are lactating and who are breastfeeding.
It's a small, but it is secreted in breast milk, but the proportion is not very high. But again, I don't think you want to do that. If you can help it.
There are one more question is, I have gone up to 10 milligrams of lamberexant. Patients' insomnia has not improved. Can I combine this with benzodiazepine or any other drug?
So I have a patient that from before that is lactating. And what she does is that she does not pump her breast milk. She gives she saves her milk during the day and she feeds baby at night. So she does not have levorexin, even minimal amounts in the breast milk. So that's one thing if you really need to use something like that. That's what she does. She pumps her milk.
Theoretically, there's a question. Theoretically, there is some role of orexin receptors in eating disorders, especially bulimia. Is there any role for DORA in that such patients? That's the question asked by someone. Madam.
I think they have done animal studies on that. In fact, because orexin was, as Madam had already mentioned, it was detected in, it was actually advocated, there's no trial or studies, but they have mentioned that in patients, because it reduces the craving, it may be helpful in patients with bulimia as well as anorexia nervosa, and people who have binge eating with bulimia. So there it just says that hypothetically it should work and it should have some effect. And animal studies, they have found that there is some amount of satiety and reduced food intake that has.
Mainly what the literature says is the night feeding behavior is reduced when you're using DORA like antagonist. So particularly in OSA and all, we see people getting up in the middle of the night and they crave for eating. And when someone is on Z-drugs also, we see that they have nocturnal feeding habits also. So this has come down with DORA according to the literature. Some of the studies have mentioned about this, but we don't have any experience.
Now, in SUDs, especially substance use disorder, once the withdrawals are over, one of the common symptoms with the patient's family come back is insomnia. Patient is not sleeping. What drug to be given? I'll start with Vinod, and all three psychiatrists can.
I think lemborexant or any DORA would be a very good option. In my mind, the substance misuse world is because of the kind of a wonky prefrontal cortex. There's not so much control a person has over consumption. So there's a restless mind, an anxious mind. So they discover either sugar, alcohol, or other drugs of choice to calm the restless mind. And you can detox people. You can help them come off the sort of addiction, but the primary problem remains. And if we can kind of calm the mind down and get the diagnostic clarity and so on and so forth. But I think lemborexant or any DORA would be a very good option.
Dr. Chitranjan?
See, in patients with alcohol use disorder, relapse is contingent on withdrawal symptoms developing after the patient is detoxified and discharged from the hospital. So the classical treatments for substance use, for alcohol use disorder include disulfiram, which doesn't address these withdrawal symptoms, these symptoms like sleep disturbance and so on. Naltrexone, acamprosate, baclofen, none of these really address the problem. Some recent studies, randomized controlled trials, have found that prazosin and gabapentin both work in keeping patients sober, improving outcomes in patients with alcohol use disorder, at least in the short term, like 3 months. And both these drugs, prazosin and gabapentin, appear to work better in patients who have more alcohol withdrawal symptoms. Now, why are they working? They're working because they're GABAergic. They're working because they reduce, at least a short-term study showed that they actually reduce the severity of alcohol withdrawal. Prazosin is sedating, gabapentin is sedating, both improve sleep. And between prazosin and prazosin goes up to 16 milligrams at night, and gabapentin goes up to 1,200 milligrams at night. Between them, they work very well for reducing the risk of relapse into alcohol dependence. Now, all that lemborexant would do would be improve sleep. It wouldn't improve any of the other aspects which prazosin and gabapentin do. So I would go with the prazosin and gabapentin first, but if the patient only has sleep disturbance, I would definitely not want to prescribe a benzodiazepine or a Z drug. Lemborexant obviously makes sense.
Yeah.
Because some studies have shown orexin 1 and 2 receptors have a role in addiction, bringing down the craving, improve the quality of sleep, and the abstinence is for a longer time while they are on theoretically.
Right, because of the effect on the nucleus accumbens, the reward system. But I really like your comment about prazosin because I'm thinking alcohol is a very strong REM suppressant as well. So when you withdraw, this is why they get these hallucinations. It's almost like they're having REM behavior disorder. So that makes sense with the prazosin because that actually also suppresses the REM.
Again, Dr. Andrade, lamborexant safety profile in patient with liver dysfunction. We know it's excreted mainly through CYP.
So lemborexant is extensively metabolized. The metabolic enzyme is CYP3A4. Lemborexant, if I remember correctly, has been found to be safe in patients with mild liver disease. In patients with moderate liver disease, the recommendation is to not exceed a dose of 5 milligrams at night. In patients with severe liver disease, it hasn't been studied and it is not recommended. I think in patients with renal failure, there's no problem because it's negligibly eliminated through renal excretion. It's almost completely metabolized by 3A4. And if I can use this opportunity to remind the audience, we use a lot of drugs that act on 3A4. For example, fluvoxamine inhibits 3A4. Modafinil, R-modafinil, carbamazepine, oxcarbazepine, the older anti-epileptics, they all induce 3A4. So you need to be aware of the potential for drug interactions if you're prescribing lemborexant with any of these other drugs.
Along with grapefruit juice.
But I don't think we are drinking much grapefruit juice here in India.
That's
are
one
we?
of the indications in the book. Now, coming to Dr. Shivkumar.
Macrolide antibiotics, if you wish.
Yes.
Erythromycin, clarithromycin, but not azithromycin. Azithromycin is okay.
Now, the role of lamborexant in management of delirium. This is one of the questions from neurologist.
Yeah, so delirium is an challenging problem in the ICU. So we have two situations here. One where whether we can prevent delirium happening in the ICU patients. So we have data for this DORAs where they are used for prevention of delirium in the ICU, and they found that particularly suvorexant has shown that we don't have suvorexant in India at this point, that we can reduce the episodes of delirium happening in the ICU patients. So that is one of the preventive aspects. But as someone who is already having delirious behavior in the ICU with a lot of sleep transitions, a lot of sleeping issues, hallucinations, agitation, and restlessness, DORA, particularly lamborexant, has shown that it is a good molecule for you to use in the ICU. It can reduce the delirium episodes. It can bring back the sleep-wake transitions or reversal of the sleep-wake cycle, what is happening in the ICU patient. So it is a good drug and a lot of advantages. One, it does not have drug interactions. It does not have too much of sedation in the daytime, which we don't require in the ICU patients. And three, it induces natural, or what we call it as sleep architecture is well preserved when we use DORA in particularly these kind of elderly patients who are delirious at this point. So it's a good thing we use in ICU patients, but we use probably in patients who are already having delirious. We have not tried in patients who have not had delirious.
And also it doesn't cause respiratory distress. That's another advantage in this.
Or on
Ventilator, etc.
I think I had a patient who had diffuse Lewy body disease, and then he goes for in delirium or like 2-3 once in 2-3 months the patient becomes delirious. So initially there is a insomnia for a day or two, then becomes agitated and hyperactive, and then after a week it settles. So it's a caregiver burden which is too much. So she takes lamborexant currently whenever the first episode of insomnia starts. So intermittently she's on lamborexant. So because they don't want to continue, otherwise the sleep is normal. So that delirium, I've seen that it gets prevented when you give. Otherwise, routinely we don't give. But this one patient where we have been like the first step is always insomnia. So at that point, it has really helped in such.
Thank you. There's another question. Can we give this lamborexant to the shift workers because of the sleep-wake cycle disturbance? Yes, that has been highlighted in today's presentation. But especially our young adults who are working in that shifts the studies have shown those who are sleeping less than 6 hours a day have high risk of cardiac mortality at the age of 35, 6 times more than the normal people, their peers. So those people can be benefited with using this lamborexant in the shift workers.
Oh, but please remember, you should be in bed opportunity of 7 to 8 hours. So if you're only planning to sleep for 3 hours, if you're a shift worker, it would not be a good idea. So all these medications.
Vinod, This is
Yes, sir.
DORA recommended in adolescents with,
They will have that.
is DORA in adolescents
good.
with the polysubstance use, insomnia, and associated anxiety symptoms? And if someone has childhood trauma, do you use DORA in such adolescents who have all this problem? Polysubstance abuse, childhood trauma, and sleeplessness.
So, I think, my experience with Limborexant has been for like the last 2 years. It's really gone up in the last 6 months. And I've personally been using it. So I have kind of, real live data to share. So, and the response can be quite variable, but definitely, sir, I have not used it under 18 as yet, obviously because of the obvious medical legal reasons. But I don't see if I have to, then it can be done with the consent of the client and off license, of course. But what you're referring to, the kind of profile you were talking about, so this is the kind of polysubstance misuse, impulse control disorder, emotional dysregulation, a lot of topsy-turvy sort of lifestyle and so on and so forth. A lot of potential, but they're not kind of making it somehow. I would immediately be thinking about them having either ADD, ADHD, and then I would do a more kind of thorough and nuanced assessment and get the diagnostic clarity and then treat that. That's what I would do, sir.
Fact, we have used for a few patients who are less than 18. That was not a chronic use, but patients who actually had ADHD and an epileptic encephalopathy, where we could not get a EEG because the patient would never sleep. And especially in that setting where you give Phenergan, you give trichlorphos, and that the child does not sleep. So in such situation, we have tried, we gave 5 mg of Lamborghini, it did not work. We gave 10 mg and it did work. So because we need to have an EEG at certain times, it becomes imperative for us to treat the epileptic encephalopathy. We need to know what is happening. So in such situations, we have given for patients who are even less than 18 years as an intermittent, like just a day or two, and it has worked well. Like they do well, and in that short scenario, we have not seen any adverse effects.
This one question to madam. What's the role of DORA, lamborexant, in intellectual developmental disorders like in elderly person with IDD having some issues related to insomnia? Can we use lamborexant in such? Yes.
Yes.
Thank you.
It
Shivkumar,
does not, it did not cause metabolic dysregulation or did not increase weight in the trials.
in elderly individual, probably patient has come with post-stroke behavioral issues, especially after post-stroke, many patients will have, especially depression, other things, 70% of them, sometimes they say up to 40%, they have associated insomnia. What is the drug of choice when you use in such patients where history of CVS, cerebrovascular accident was there, severe?
I think the advantage of Limborexant is primarily in terms of the issues related to kind of daytime somnolence, as well as problem with withdrawal symptoms, as well as cognitive impairment. So I think all these things will be useful advantage in the context of stroke, as well as any elderly individual. I think this will be one of the good choices which can be considered. I think in terms of drug interactions, again, except for 3A4, it is okay. And renal dysfunction, it's not a problem. So only hepatic dysfunction is a problem. So that way, I think elderly people, it is a good choice compared to benzodiazepines or Z-drugs. Among the choices, what we have with that, I think the false risk is a big concern. But only thing what we need to see is that in the long-term usage, I think when the Z-drugs came, it was thought that, okay, it will not be that much of a problem. But I think over a period of time, it is we need to see as to how much these advantages are sustainable in the long-term evidence. Because most of the studies now are up to 1 year.
Okay.
Particularly the problem what we face in stroke is the rehabilitation. So when we start using most of these drugs which are sedating, the next day they are not either cooperative or they will not be going to the rehab at all. So this is a big challenge for us. And so that's why either we don't use any sedatives or we use probably a DORA or maybe a small dose of quetiapine for them for sleep in the night. Otherwise, we tend to avoid the benzodiazepine.
Yeah, important if post-stroke, look for sleep apnea. We did a study in the where our rehabilitation center, And we just screen everybody, and it's 30% with sleep apnea and insomnia.
Our rates are up to 60%.
In your centers, yeah. So it's
Almost
pretty,
60% of stroke patients.
so that could be another cause of sleep fragmentation and daytime sleepiness. So that's something that needs to be done.
In our context, sleep apnea is very, very minimally detected. Almost, particularly in the psychiatric patients, many of them will be on benzodiazepines. And when it comes to elderly, even those who are not very obese, who are actually do not kind of warrant that kind of suspicion. When you actually do the polysomnography, you pick up people with mild, moderate sleep apnea. And I think in those kind of patients, even in persons with dementia, we found using any sedative medications, particularly benzodiazepines, have worsened the behavioral problems, and taking out, actually identifying and deprescribing itself leads to improvement, and then CPAP, with that itself, it is improvement. When we have to use, I think lemborexant, even for a short-term use or this thing, it can be a potential choice which can be considered.
Though Madam has told that in patients with OSA, 40% of people can have associated insomnia apart from obstructive sleep apnea. So those CPAP is given, still they come back with not able to sleep adequately or wake up fresh in the morning. So lamborexant is a drug of choice. Dosage.
Also, if they have COMISA, they cannot use the CPAP.
See, that's what, along with CPAP.
Oh, no, they can't. They will be not compliant with the CPAP because there's sleep disruption. The CPAP will actually disrupt the sleep of an insomnia patient even more.
So initially, when we start them on the PAP therapy, most of them are very reluctant. They don't accept the mask and they are restless. Or when they get up for going to the restroom, they remove the mask and after that they don't wear. So the duration of usage of PAP is a big problem for us when we use the PAP therapy. So what we use is initially to increase the compliance, we use a sedating dose of melatonin or a DORA initially for first few weeks till they become accustomed. Once they get the feel of kick of using the PAP and they're benefiting it, then slowly we start tapering the DORA or the melatonin in the sedating dose, and then they become comfortable. So in the initial stages, we have to make them accept the PAP therapy. So it's important to take care of the sleep. The advantage of DORA is that it does not interfere with respirations, nor it causes any fragmentation of sleep. It causes a very natural sleep architecture. So it is an advantage for us to use either melatonin or DORA in PAP therapy initial stage.
Thank you. Now, before we conclude, I'll start from Dr. Shivkumar. Dr. Shivkumar, where all you use DORA, especially lemborexant in your practice for the people to understand?
Yeah, I think in geriatric practice, we have primarily used in people who are coming primarily with sleep issues. Many of them have concern. They also come saying that you don't start something which I'll get addicted. So that is something, a psychological issue of avoiding sleeping pills. Some of the elderly are very, very particular about that. And then even in dementia or people with MCI, where cognition is a concern and false risk is a concern, and those patients we have used. And the early responses, we're quite happy with the initial whatever experiences we've had. I think I would say I have used not that extensively because of financial. A lot of patients who come to demands may not be affordable, but there are people who are affordable elderly. We have used, and at least a handful of patients who have stayed through and who had a positive feedback.
Thank you. Dr. Vinod, apart from what are the indications, where all other off-label users you are using DORA?
So my practice for some reason has I think I would say 95% is what I call as neurodivergent syndromes, and I think a lot of sort of psychiatric manifestation can be explained by sort of masked ADD and ADHD and OC and RD. OC and RD is very common amongst particularly intelligent people, professionals, highly functional people. I think a lot of us here would definitely qualify for OCPD sort of cutoffs and so on and so forth. So so that is what my practice has become, sir. And then when we do very nuanced and thorough kind of psychometric assessment, and we get the kind of profile of a client who definitely has masked ADD at the very least, or like frank ADHD and so on. So then obviously the gold standard treatment there is methylphenidate and other stimulants and so on. So the struggle I have with that is to kind of get them to take that consistently, because stimulants will obviously further disrupt the sleep pattern and so on. So I've been harping on about this, like methylphenidate or whatever brand works best on a rested mind and a fed tummy, right? And the rested mind and with the limborexant, I've found the kind of holy grail of that. That's what I think. Yeah, and I've been seeing that in my practice over the last at least 3 to 4 months, and it's phenomenal. I talk less now.
Thank you. Now, Dr. Divya, you're in a primary institute. Role of lamborexant in your practice. Quick.
Yeah, first and foremost, insomnia, short term, long term, with comorbidities and even primary. So, as Madam mentioned, there's no primary or secondary, it's a disorder. So, that definitely first. Second, in patients who are having delirium, who are either secondary to Alzheimer's disease or frontotemporal dementia or Parkinson's disease. Third, I have given in patients when we are unable to take EEG in patients with ADHD, especially because it does not affect the sleep architecture or the epileptiform abnormalities. So both are equally important, which limits the use of other drugs. So, and patients, especially with epilepsy, who after a sleep deprivation can have epilepsy. So those patients where insomnia is a real troublesome problem, because next day they can have a seizure. So these are the 4 indications I would definitely.
Quickly adding to Dr. Shukmar, role of lamborexant in your ICU in seizure patients who have insomnia, migraine patients who have insomnia so that frequently they are getting attacks, or in ALS, if you have used.
ALS, I mean, we have not used in ALS. We have used in all the neurocognitive or neurodegenerative diseases. And then because we run sleep clinics and we use PAP therapy, so we use a lot of DORAs in people who have sleep apnea, with COMISA, who have insomnia, because it's a bidirectional relationship. So a lot of patients with OSA have insomnia. In addition to this, we use DORA a lot in the ICU, as Dr. Divya was telling. Delirium is a big issue, and we use a lot. I mean, all other indications have been covered by this.
Thank you. Now, Dr. Chittaranjan, to wind up.
Oh, I totally agree that there are multiple instances where DORAs may be beneficial because of the safety, I think efficacy, the safety profile as well. I think the new areas that I'm pretty excited about is the delirium. I think it's amazing, actually, the response. You would think it would take a lot more to get the patient, to be non-delirious, because they don't respond to the other things. So that's an area that I think needs to be studied a little bit more. Thinking the ICU, stroke patients. There's another area that the cardiologists talk about. So with people with cardiovascular disease, like with heart disease or angina, they appear to be okay because they also have an activation, and it's been used now in patients with congestive heart failure because they have high sympathetic drive and they have a lot of insomnia. Appears to be also safe in that group.
Thank you. Dr. Chittaranjan, to wind up your comments.
How much time are you giving me?
You are the
I'd be as
person.
brief as possible.
Yeah.
Just some concluding remarks. One thing I noticed, tranylcypromine didn't come into the picture at all. Tranylcypromine causes severe insomnia in some patients. And we are going to be prescribing tranylcypromine for a very long time. We cannot prescribe zolpidem or zopiclone or esopiclone for a very long time. We cannot give a sedating antidepressant like amitriptyline or dotipine with tranylcypromine. What are we going to do? So lemborexant is an excellent option for patients with severe insomnia with tranylcypromine. Remember, we are not talking about doses of just 30 milligrams to 60 milligrams per day. Some patients require up to 90 or even 120 milligrams per day of tranylcypromine. Okay, so for concluding remarks, We have insomnia, as Dr. Z pointed out, with difficulty in falling asleep, with middle of the night awakenings, with early morning awakening, with impairment in the quality of sleep. And the drugs that we had so far didn't act on everything. Zaliplon, very short duration of action, half-life of 30 minutes to 2 hours. Patient sleeps for about 2 or 3 hours, wakes up afterwards. Zolpidem, half-life of 2 to 4 hours. Patient takes the zolpidem, falls asleep very easily, but wakes up in the early hours of the morning because the effect of the zolpidem has worn off. Sustained release zolpidem does not do very much better unless you're giving it in high doses like 12.5 milligrams. S-zopiclone and S-zopiclone, longer duration of action, 4 to 7 hours, but it leaves a bitter taste in the mouth. Patient doesn't like it because it's excreted in saliva during the course of the day, and the patient has this nasty taste in the mouth for the whole day, doesn't want to take the drug. Drugs like tricyclic antidepressants in low doses, for example, 10 to 25 milligrams of amitriptyline or 25 to 50 milligrams of dotipen, or low doses like 3 milligrams of doxepin,
3 to 6
3
milligrams,
to
very
6
effective.
milligrams of doxepin, useful, but useful more for maintenance of sleep rather than for induction of sleep. So if we want to give something for inducing sleep, it doesn't maintain sleep. If we want to give something for maintaining sleep, it doesn't induce sleep. If we give something like melatonin, melatonin doesn't work for everybody. It works only for some people. And in those people for whom it works, it doesn't work all the time. Ditto for ramiltion, which also acts on M1, M2 receptors. So what are we left with? And this is where the DORA drugs come in. Now, DORA drugs as antagonizing wakefulness doesn't mean that the sleep is natural. I mean, it works through a neurotransmitter system, but drugs that work on GABA receptors also work through a neurotransmitter system. It just works through a different mechanism. That's all. But the advantage is the DORA drugs induce sleep and they maintain sleep as well. How do we dose lemborexant? It is dosed at night on as empty a stomach as possible. Now, this becomes problematic practically because patients tend to eat dinner at maybe around 8 to 9 p.m. And they have to wait for the stomach to empty, which takes about 1.5 to 2 hours, which means 10:30 before they can take the DORA. If a DORA, or for that matter, any hypnotic is taken after food, food slows down the absorption and delays the onset of action of the drug. Now, Tmax with the DORA with lemborexant, time to peak blood levels is 1 to 3 hours, which means that if it is taken with food, there's an even longer time to Tmax, delaying its onset of action. And we don't want that. So we need to make sure that we tell the patient, eat your dinner a little earlier, make sure there's at least 1.5 hours, 1 to 1.5 hours gap before you take your drug, and expect it to make you to feel sleepy within the next half an hour. So you should be ready to go to bed within half an hour. And because it has a long duration of action, the half-life of lemborexant is 17 hours,
Yeah, more than 12.
something
Yeah,
like 17 hours, right? Make sure that you have at least 7 hours of sleep time until you have to get up in the morning. Like, don't take lemborexant at say 11 o'clock and set your alarm for 4 o'clock because you have an early morning flight. That doesn't make sense at all. You need 7 hours of sleep time if you're going to be taking lemborexant for it to be meaningfully effective. All right. Now, half-life of 17 hours, what happens when the patient wakes up in the morning? Is there daytime drowsiness? If you look at the literature, the answer is no. But let me share with you a personal experience. I lead a lifestyle where I have travel, where I have deadlines to meet, where very often I have to stay up late at night, where my sleep cycles are frequently disrupted. And occasionally, maybe twice a month or 3 times a month, I do need to take something to get my sleep cycles back on schedule or to help me to sleep properly. Because if you're not sleeping properly becomes a habit. I used to take something like 12.5 mg of prothiorin, half a tablet, half a 25 mg tablet, or 10 milligrams of amitriptyline. Wouldn't help me to sleep, but I would sleep well at night because sleep maintenance was good. I took 5 mg of lemborexant after I found out that it was available in India. What do you think was the result? I actually felt sleepy for 2 days. 2 days with just 5 mg. So I think I'm a little bit atypical over here, but keep in mind, lemborexant has a half-life of 17 hours. And in some patients, they may feel sleepy for more than 7 hours. Anyway, if I take lemborexant now, it's just 2.5 milligrams and it's not a problem. I fall asleep quickly. I sleep for about 7 or 8 hours and I'm fine during the daytime the next day. Keep in mind that starting with 5 mg may not be appropriate for everybody. Dr. Z showed a slide where if you look at the lines, 5 mg and 10 mg didn't really make all that much of difference. And she pointed out that perhaps everybody doesn't need 10 mg. Most people would do fine with just 5 mg. So keep this in mind. And only in some patients, like perhaps people with alcohol use disorder who are being detoxified, you may need a higher dose. Having said so, everybody is different. If I need 2.5 mg, somebody else may need 10 mg. You may need to find out what works best for different people. So, do I have anything else to add? I don't think. If you wish to add anything or Dr. Z
only
wishes
to
to add
take
anything.
two messages pigeon out from what you said. One, it should be taken in empty stomach. 8 o'clock dinner, 10 o'clock to take brush, attend to toilet needs, go to bed with this tablet, they can have a comfortable sleep. Number one. Number two, some patients in India have a habit. I go to bed by 9 o'clock, doctor. I wake up at 12 or 1 o'clock. That time they should not take this tablet to see that this is one because the half-life is more. We have to educate the patient exclusively. Don't take middle of the night. If you have, as you said, 7 hours, 7 hours, they should have enough time to sleep. These are the two things I thought of highlighting. Otherwise, you have covered everything. Now, last word before we close, Dr. Z.
No, I think this is terrific. I have also seen patients where there's hypersomnia. They have sleepiness during the day. And I don't think it's the half-life. It's probably the strength of the receptor binding. And so you have to kind of, the receptor has to be released. I mean, the strength of the binding may differ genetically or otherwise between individuals. But I do see that as well. And I do exactly what Dr. Andrade did, which is go to 2.5, just break it in half. Yeah, it's.
Thank you, madam.
Thank you.
Probably one message, last message given to the pharma is 2.5 milligrams is available in other countries. Only in India, it is not launched. Consider that we are not different from others because all the studies have not shown any difference in the race, ethnicity, and other things when the sunrise 1 and 2 are
But you
conducted.
guys did. I think, Dr. Darshana, you did 2.5 milligrams in your trials. In your original dosing, your phase 2, did you not EISAI use 2.5? Yeah, so 2.5 was still effective, just not as good. So yes, so that's why they decided not to dose it at 2.5. But the initial, not the pivotal trials, but the phase 2 trials were actually done with 2.5.
Thank you.
So it can work. I mean, it's not like it didn't work. It was just less.
I hope this was a very interactive session. Thanks to EISAI for organizing this. And we don't have any words to thank Dr. Phyllis Z, who has traveled across the globe, came to India from US, traveled across 5 cities in India, and returning tomorrow. Madam, we have no words to thank you. Thank you very much for enlightening us on every aspect of DORA. Probably, if you have followed all the slides of yours, you have answered most of the questions. This panel discussion was just to highlight and make the doctors to understand to write the prescription. Thank you very much. Thanks for all the participants across all the 4, 5 cities. Thanks to our Bangaloreans. Today being a Sunday, late evening, having many other activities, still the hall was full. Thanks to all the participants and EISAI for organizing this. Thank you.
Yeah, good evening.
Thanks to all the participants.
Yeah, good evening, doctors. On behalf of EISAI, I would like to thank Dr. Felici for traveling extensively across 5 cities in the last 4 days. And I would like to thank Dr. Chitranjan Andrade, chairperson for the day. And I would like to thank Dr. A. Jagdish, moderator for the day. And I would like to thank Dr. Shivkumar, Dr. K.P. Divya, and then Dr. Vinod Kumar, and then Dr. P.T. Shivkumar, panelist for the day. Once again, thank you very much, everyone. And thank you for each and every one of you for taking out your valuable time on a Sunday evening and hearing out this international speaker program for the last 2 hours or 15 minutes. Thank you very much. And please join us for the dinner. Thank you.
Okay, guys, allow me.
Thank you, sir. Thank you for such valuable insights. Maybe Aro. Maybe Aro.